Chapter 61, Acute Intracranial Problems. The major components of the brain are brain tissue comprising 78%, intravascular blood comprising 12%, and cerebrospinal fluid making up the final 10%. Factors that influence intracranial pressure include arterial pressure, venous pressure, intra-abdominal and intrathoracic pressure, posture, temperature, and blood gases, especially CO2 levels. Also, should a patient have a head injury and have drainage, we will culture all drainage from the ears and nose to assess for glucose and identify the presence of cerebrospinal fluid. Within that enclosed space of the skull, there's a lot that goes into the regulation and maintenance of balance. The Monroe-Kelly doctrine states that if the volume of one component increases, another must decrease to maintain intracranial pressure, and this is only applicable if the skull is closed. A normal intracranial pressure is 5 to 15 millimeters. Elevated would be considered if it's greater than 20. Cerebral perfusion pressure. The CPP equals the MAP minus the ICP minus the intracranial pressure. A normal would be 60 to 100. Less than 50 is associated with ischemia and neuronal death. The effect of cerebral vascular resistance is that CPP equals the flow times resistance. In the case of increased intracranial pressure, this is a life-threatening emergency, and the increase in any of the three components, brain tissue, blood, or cerebrospinal fluid, increases the cerebral edema. Here in figure 56-3, we have two diagrams. In A on the left, we have a normal relationship of intracranial structures, whereas in B on the right, we have a shift of intracranial structures. Cerebral edema results from increased extravascular fluid in the brain, and it has a variety of causes, everything from vasogenic, cytotoxic, or interstitial. In vasogenic cerebral edema, this is the most common type, and occurs mainly in white matter. The fluid leaks from the intravascular to the extravascular space, and this has a variety of causes, though the continuum of symptoms does eventually lead to coma. Cytotoxic cerebral edema is from a disruption of the cell membrane's integrity. This comes from a destructive lesions or trauma to the brain tissue itself. In this case, fluid and protein shifts from the extracellular to the intracellular space. Interstitial cerebral edema is usually the result of hydrocephalus, excess cerebrospinal fluid production, an obstruction of flow, or an inability of the body to reabsorb, and it's treated with ventriculostomy or a shunt. The clinical manifestations, the hallmark is going to be a change in the level of consciousness, with a flattening of the affect associated with coma. You may also see a change in vital signs known as Cushing's triad, in which a widening pulse pressure, bradycardia, and irregular respirations result. You may also see a change in the patient's body temperature. These manifestations also have what's known as decorticate and decerebate posturing. In decorticate posturing, the hands are folded up into the core, such as in figure A, whereas in decerebate posturing, the arms are straight out, such as in figure B. I'll also try to post a couple YouTube videos of these positionings in NFL players receiving significant head trauma. Our clinical manifestations would include a headache that's often continuous and worse in the morning, along with vomiting not preceded by nausea that could even be projectile. Complications include inadequate cerebral perfusion, cerebral herniation, where the pressure, as you can see, is forcing part of the brain matter actually through the skull. There may also be a tentorial herniation, an ungual herniation, or a cingulate herniation, depending on the type and where the matter is being forced to. For diagnostic studies, they're going to include imaging such as a CT scan, MRI, EEG, a cerebral angiography, intracranial pressure and brain tissue oxygenation measurement, a Doppler and evoked potential studies, and always keep in mind there is no lumbar puncture in these cases because the herniation can damage the central nervous system. As some of you may have already seen in your own practices, on the right-hand side we have the Glasgow Coma Scale that assesses the patient in three areas: eye-opening response, best verbal response, and best motor response. A score of 8 or less does indicate a coma. Here we have the potential placements of an intracranial pressure monitoring devices. Here in figure 56-6, we have that ICP monitoring that can be used to continuously measure the intracranial pressure. The intracranial pressure tracing shows normal, elevated, and plateau waves. At high intracranial pressure, the P2 peak is higher than the P1 peak, and the peaks become less distinct and start to form plateaus. When measuring, it's done with a ventriculostomy, where a catheter is inserted into the lateral ventricle, and this is coupled with an external transducer. With that ventriculostomy in place, the cerebral spinal fluid can be drained via ventriculostomy when the ICP exceeds the upper pressure parameters set by the provider. Intermittent drainage involves opening a three-way stopcock to allow cerebrospinal fluid to flow into the drainage bag for brief periods until the pressure is below the upper pressure parameters. Here in Figure 56-8, we have on the left-hand side in Figure A leveling the ventriculostomy, where in Figure B we have the cerebrospinal fluid is drained into the drainage system. With the ventriculostomy in place, cerebrospinal fluid can be drained via the ventriculostomy when the ICP exceeds that upper pressure parameter. And right here we have the way that is measured, showing the 0 line where it's placed at the level of the ear, and the black arrow on the chamber indicating the pressure level set by the surgeon. When measuring intracranial pressure, it's measured as a mean pressure, and the waveform should be recorded in terms of normal, elevated, and plateau waves. You want to immediately report any elevated intracranial pressure, and be very proactive in preventing and monitoring for infection as well. We also want to evaluate changes with the patient's condition. Inaccurate intracranial pressure readings can be caused by cerebrospinal fluid leaks, obstruction in the catheter or kinks in the tubing, differences in height of the catheter and transducer, an incorrect height of the drainage system, and bubbles or air in the tubing. When measuring cerebral oxygenation and perfusion, Lycox and neurovent catheters can be used to measure brain oxygenation and temperature, and are placed in healthy white brain matter. On the other hand, a jugular venous bulb catheter measures the jugular venous oxygen saturation. Here in Figure 56-9, we have the Lycox brain tissue O2 system that involves the insertion of a catheter. On the right-hand side, the system measures O2 in the brain, tissue, temperature, and intracranial pressure simultaneously. We want to focus our nursing assessment on the cranial nerves, including things like eye movements, corneal reflex, the oculocephalic reflex or Dall's eye reflex, or the oculovestibular or cold caloric reflex. When assessing the pupils, we want to be aware of both their size as well as response, and keep in mind the acronym PERLA. Are the pupils equal, round, reactive to light, and accommodating? Other assessments would include motor strength, which we'd accomplish with hand squeezing, pronator drift test, or raising the foot off the bed or bending the knees. We may also assess their motor response as spontaneous or to pain. Here in Figure 56-11, we have examples of abnormal respiratory patterns of a coma, with examples like Cheyne-Stokes, central neurologic hyperventilation, or cluster breathing. Let's talk head injuries. A head injury, just like it sounds, is any trauma to the scalp, skull, or brain that could even lead to much more serious complications, such as traumatic brain injuries or hidden bleeds. The most common causes are falls and motor vehicle accidents, with other causes including firearms, assaults, sports-related trauma, recreational injuries, or even war-related injuries. Traumatic brain injuries are twice as common in males and have a high potential for poor outcomes. These deaths occur at 3 points after the injury, immediately after the injury, within 2 hours after the injury, or about 3 weeks after the injury. Skull fractures are another major concern, with the location determining the manifestations. Complications include everything from infections and hematoma to tissue and brain damage. Another indication of a head injury are raccoon eyes and battle signs. In Figure A, we have raccoon eyes along with the rhinorrhea, while in Figure B, we have battle sign, which is that post-auricular ecchymosis. In Figure C, we have another indication of that battle sign, that bruising back behind the ear. And in Figure D, we have halo or ring sign. Here we have another example with battle sign on the left, which is that bruising that occurs behind the ear, along with raccoon eyes, which is that bruising of the blood pooling over the eyes. Other types of head injuries include diffuse injury or a concussion, which is a sudden transient mechanical injury that results in a brief disruption in level of consciousness, retrograde amnesia, headaches, and may even result in post-concussion syndrome. At the end of this video, I do have below it another video of Tua Tagovailoa's 3 concussions in 90 seconds that gives you a good example of what a concussion is. Post-concussion syndrome is a persistent headache resulting in lethargy, personality and behavior changes, shortened attention span, decreased short-term memory, and changes in intellectual ability. Another type of head injury that's very common secondary to motor vehicle accidents is called a coup-counter-coup injury. And in this case, after the head strikes a wall, a counter-coup injury occurs as the brain strikes the skull. The counter-coup injury would then be the second impact of when the brain strikes the skull surface opposite the side of the original impact. Much like getting in a car wreck and then bringing your head straight back. Another major complication would be an epidural hematoma, and this is the bleeding between the dura and inner surfaces of the skull. It is a neurologic emergency. In the case of venous origin, it has a slow onset, whereas an arterial origin has a rapid onset. And in this case, it may even possibly be treated with a craniotomy to reduce the pressure within the skull. Here in figure 56-14 from the text, we just have the locations of the epidural, subdural, and subarachnoid hematomas, or bleeds within the brain. An epidural hematoma may result in initial periods of unconsciousness, along with brief lucid interval followed by a decrease in the level of consciousness. Headaches, nausea, vomiting, focal findings, and these require rapid intervention and evacuation. And here in figure 56-15, we have the epidural hematoma covering a portion of the dura. Note the multiple small contusions that are seen within the temporal lobe. A subdural hematoma is the bleeding between the dura mater and the arachnoid space. The most common source are veins that drain the brain surface into the sagittal sinus, and could also be arterial that develop more rapidly. In the case of an intracerebral hematoma, this is bleeding within the brain tissue and usually happens within frontal and temporal lobes. The size and location of the hematoma are key in determining the patient outcome. Keep in mind other major risk factors are going to be any patient on blood thinners that are also at an increased risk of a brain bleed during injury. Also, keep in mind, do not ever give aspirin when a stroke or a brain bleed is suspected. For our emergent treatment, it's going to be circulation, airway, breathing, stabilizing the cervical spine, along with oxygen, IV access, intubation if the Glasgow scale is less than 8, controlling the external bleeding, and removing the patient's clothing. In the case of skull fractures, we're going to first go with conservative treatment, though surgery if necessary. For a subdural and epidural hematomas, surgical evacuation may be necessary, including craniotomy, burr holes, or even craniectomies if extreme swelling is expected. For acute care, especially if a patient is leaking cerebrospinal fluid, we want to make sure the head of the bed is raised, have a loose collection pad under the nose or over the ear, reminding the patient about no sneezing or blowing the nose so nothing increases the pressure, no NG tubes, and no nasotracheal suctioning. We mentioned on the previous slide about no NG tubes with these sorts of head injuries, and this is why. As you can see, especially right there in the middle, is imaging of where a patient was given an NG tube, and instead of it going down the throat, it's actually wound up within the skull. That the layer separating the brain from the nasal passage is very thin in the back, and if there is a head injury that fractures that, there's not a lot separating that NG tube from going straight back into the brain. And up above it, you just have the same phenomenon from a different angle. Inflammatory brain disorders. The most common inflammatory conditions to the brain and spinal cord are brain abscesses, meningitis, encephalitis, which has a 10 to 15% mortality rate, and some who recover have long-term neurologic deficits. Bacterial meningitis. This is an acute inflammation of the meningeal tissue surrounding the brain and spinal cord. It usually occurs in fall, winter, or early spring, and is often related to a viral respiratory disease. There is mandatory reporting by the CDC, and unfortunately this condition has a mortality rate of 50 to 100% if treated. It's another one that there is a vaccine for. It's recommended to vaccinate all teenagers, college freshmen, and new Army soldiers, or even anyone living in cramped close quarters. The leading causes of bacterial meningitis are Streptococcus pneumoniae or Neisseria meningitis. It's replaced Haemophilus as the flu vaccine emerged. Other organisms that enter the CNS through the upper respiratory tract or bloodstream, or may even enter the skull wounds for fractures within the sinuses. In the case of inflammatory response, you're going to have increased cerebrospinal fluid production, along with purulent secretions that spread to other areas of the brain through the cerebrospinal fluid, cerebral edema and increased intracranial pressure becoming problematic, and if the process extends into the parenchyma, or even if its concurrent encephalitis is present. Key signs of meningitis include fever, severe headache, nausea, vomiting, nuchal rigidity, coma, often associated with a poor prognosis, and unfortunately it occurs in 5 to 10% of cases. Other symptoms that may be present include photophobia, decreased level of consciousness, and signs of increased intracranial pressure. Seizures can occur in about 1/3 of cases, as the headache worsens, and vomiting and irritability that may also be present. For complications, increased intracranial pressure is a major cause of altered mental status. This in addition to the residual neurologic dysfunction within many of the cranial nerves that can also become dysfunctional. Hemiparesis, dysphagia, and hemianopsia. If you suspect the following, if the above do not resolve, we're going to be looking at things like a cerebral abscess, subdural empyema, subdural effusion, or persistent meningitis. For diagnostic studies, these would be done with a blood culture, CD scan, and the diagnosis verified by things like a lumbar puncture, analysis of the cerebrospinal fluid, specimens of secretions that are cultured to identify any causative organism, as well as the gram stain to detect the bacteria. For viral meningitis, the most common causes are enterovirus, arbovirus, HIV, or herpes simplex virus. They most often spread through direct contact with respiratory secretions and are usually present as a headache, fever, photophobia, and stiff neck. Encephalitis is an acute inflammation of the brain that comes along with serious and sometimes fatal disease. Usually caused by a virus, some are endemic to certain geographic areas and regions. Other causes like ticks and mosquitoes can transmit epidemic encephalitis, as well as CMV encephalitis that occurs in patients with HIV and AIDS. And finally, for nursing management, we're going to be looking at drugs like acyclovir and other antivirals that work to decrease the mortality rates, as well as the neurologic complications that may still occur. Start treatment before the onset of coma, and consider anti-seizure drugs for seizures that may be started prophylactically. But anyway, that's all we got for this chapter. You'll notice 3 videos down below this one. All 3 are very short and give you a good idea of the different posturing and effects of serious neurologic trauma. Like I said, each one are between like 30 seconds and 90 seconds. But just be good examples. But anyway, that's all I got for this chapter. I'll see you in the next slides.